All the participant lines are going to be muted during today's event. If you have questions, you can address them by sending them through the chat or Q&A function, and we will get to them as time permits. And I'm going to hand it over now to Claudette Powell.
Webinar, thank you for joining us. I'm Dr. Claudette Powell, Director of the Division for Healthcare Quality at the Office of Disease Prevention and Health Promotion within the Office of the Assistant Secretary for Health at Health and Human Services. I have the privilege of presenting our first speaker, who is the Acting Assistant Secretary for Health, Dr. Don Wright. Dr. Wright will provide an overview of the National Action Plan for Adverse Drug Event Prevention, and he will also review the national measures and targets for ADEs in acute care hospitals. Dr. Wright.
Claudette, I think you might just want to go ahead.
I'm sorry? Shall I just go ahead and proceed until we can get Dr. Wright?
I think you have the authority. It's 8 minutes past the hour.
Yes. All right. Let's roll on. Thank you. Anyway, we thank you all for the opportunity of joining you today to discuss ways that we have been working together to reduce the risk of preventable adverse drug events. In Dr. Wright's role as Acting Assistant Secretary for Health, he would like to express his appreciation for the work that you all do every day to help improve patient safety and healthcare quality for Americans. Dr. Wright also serves as the Director of the Office of Disease Prevention and Health Promotion, or ODPHP. And today, Dr. Wright, or myself, will be focusing on one of our initiatives at ODPHP, the National Action Plan for Adverse Drug Event Prevention. Next slide. As we are all aware, adverse drug events, or ADEs, are a significant public health problem. We know they can happen in any healthcare setting, including inpatient, outpatient, and long-term care settings. ADEs are more likely to occur during transitions of care and may stem from inadequate transfer of information between healthcare providers and also poor communication between providers and patients. ADEs occur millions of times every year, costing an economic burden in the range of billions of dollars, and they cause harm to individual lives. CDC data show that ADEs were responsible for 1.3 million emergency department visits in 2013 to 2014, with 350,000 of those visits resulting in hospitalization. Next slide. We use the national rate of hospital-acquired conditions, also known as HACs, to track changes in ADEs since the CMS Partnership for Patients was launched in 2011. The data for 2014 estimated a rate of 121 HACs per 1,000 hospital discharges. This was down from 145 in 2010. Of the 120 HACs per 1,000 inpatients in 2014, we estimate that about 24 were hypoglycemic adverse events, and 17 were due to 3 types of anticoagulants. Taken together, adverse drug events associated with these 2 types of medications represented a third of all the HACs that we measured and included in the national HAC rate. Next slide, please. We know from national surveillance data that there are a few drug classes that cause the vast majority of these ADEs. On the inpatient side, for example, adverse events from diabetes agents and anticoagulants comprise 1/3 of all the hospital-acquired conditions that are being tracked as part of the Partnership for Patients initiative at CMS. In 2014, there were an estimated 780,000 hypoglycemic adverse events, or 24 hypoglycemic adverse events per 1,000 discharges, and an estimated 570,000 adverse events associated with anticoagulants. That's approximately 17 anticoagulant adverse events per 1,000 discharges. Now, on the outpatient side, anticoagulants, diabetes agents, and opioid analgesics also cause the majority of emergency department visits for ADEs, and these are associated with clinically significant and serious adverse events, including hemorrhage in over 3/4 of estimated ED visits for anticoagulant adverse events, hypoglycemia with moderate to severe effects like shock in almost 1/2 of the estimated ED visits for diabetes agents, ADEs, and then moderate to severe neurologic effects in 1/3 of estimated ED visits for opioid ADEs. Next slide, please. Now that we've reviewed the scope of the problem, I'd like to give you a little background on the development of our National Action Plan. In December 2011, the U.S. Senate sent a bipartisan letter to the Secretary for Health and Human Services requesting that the department convene a federal interagency task force in order to identify patients at risk for ADEs and opportunities to improve the care provided to the patients who were at the highest risk for ADEs. The following year, in September 2012, the Office of the Assistant Secretary for Health marshaled the wide-ranging and diverse resources of federal partners to form an extensive interagency partnership whose goal would be to develop a national action plan for ADE prevention, and that ADE action plan was released in 2014. Now the national targets and measures are available for the action plan. Next slide. Based on national ADE data from inpatient and outpatient settings, the ADE action plan focuses on 3 high-priority ADEs that are common, clinically significant, preventable, and measurable. So measurable in terms of bleeding associated with anticoagulants, hypoglycemia associated with diabetes agents, and accidental overdose from opioids. Next slide. The ADE targets and measures are available on health.gov and were chosen on the basis of the following considerations. First, they address ADEs in both inpatient and outpatient settings. Secondly, they are outcomes-based rather than process-based. Thirdly, they are derived from surveillance systems that are nationally representative, systems that can provide baseline estimates from which to measure progress on prevention, and which use consistent and stable ADE measurement methodology for the foreseeable future. They align ADE measurement with other departmental medication safety measures and goals. So, for example, CMS's Partnership for Patients and ODPHP's Healthy People 2020. Next slide, please. These national targets and measures are meant to track population-based ADE harm on a national level with a focus on those 3 drugs, the anticoagulants, diabetes agents, and opioids. However, they do not replace regional, local, or facility-level tracking of ADEs, and they do not affect reimbursement. But they will provide a national view of progress on the ADE action plan. HHS is aiming for a 10% national reduction in these ADEs by the year 2020, using 2014 as a baseline. These measures align with other departmental medication safety measures and goals, such as those included in the CMS Partnership for Patients initiative, as I mentioned, as well as Healthy People 2020. In closing my section here, I would like to thank our partners again for bringing us together today. We look forward to continuing to work with our federal partners as we aim to achieve the new targets and measures for ADEs by 2020. Next slide, please. We will have an in-depth view of national targets and measures presented by Noel Eldridge and Andrew Geller.
Thank you, Dr. Powell. Can you hear me okay?
Yes, I can.
Yes, it's Noel Eldridge. Next slide, please. So I'm going to talk about the inpatient measures that we presently have and that we're developing to track adverse drug events in the three topic areas. The first one is the anticoagulants, and you can see in this table here, the measure is simply a rate of anticoagulant adverse events among U.S. inpatients. The numerator is the number of patients that have those adverse events, and the denominator is the number of patients that get those drugs administered to them while they're in the hospital, and the target reduction is 10%. And this aligns with the departmental measure in the Partnership for Patients Initiative. Likewise, the same is for hypoglycemic events. For anticoagulants, we have three drug types at present. We have heparin, IV heparin, low molecular weight heparin, and warfarin. We're adding, in the longer run, a new class of the newer anticoagulants that will make the measure more representative of all the drugs being used on inpatients. For hypoglycemic, we have inpatient insulin and other hypoglycemic agents. And similarly, the numerator is the number of patients that have adverse events, and the denominator is the number of patients that get those drugs administered during the stay. And for opioid events, similarly, number of patients that have the adverse events and the number of patients that get the drugs. At present, we have lots of data, going back to 2005 actually, data that's pretty heavily analyzed on these first two measures, the anticoagulants and the hypoglycemic. On the opioid analgesics, we're still developing and tweaking and improving our inpatient measure. At present, we have developed pretty good data on the denominator, the number of patients getting inpatient opioids, which is a new data point that we didn't used to have. But we're still working to improve the numerator so that it's fully representative of the patients that experience adverse events during their stay, and that it doesn't overstate the number. The opioid adverse events are easy to mistake for other types of events. Next slide, please. The data comes from the Medicare Patient Safety Monitoring System, and we've been running this with CMS since 2002, and we've typically got 30,000 charts a year. In recent years, we've been using this, what we call a four-condition sample of patients with AMI, heart failure, pneumonia, or major surgery, and we're adding another group of patients that complement these patient groups, basically everybody other than those four groups of patients over 18 years old. And the software that we use, the Medicare Patient Safety Monitoring System software, is a tool that is used at the CMS Clinical Data Abstraction Center, where trained professionals go through the charts and look for the events in response to questions that determine if the events occurred. The new system that I mentioned before, that's going to include the previous adverse events plus opioids, is the QSRS system, and that's presently working, but we don't have any data to report from that one yet. And I'll turn it over to Dr. Geller for the remainder of the presentation.
The outpatient targets and measures. So just as was the case for the inpatient measures, we have measures that have been improved for each of the three drug classes, the anticoagulants, the insulin, and opioid analgesics. In our case, for the outpatients, the numerator will be the number of visits to hospital emergency departments in the United States for adverse events from one of the three drug classes. And our denominator data will be the number of unique patients who receive a prescription for one of these three drug classes. Our target reduction is 10%, and for the first two of the three measures, they are established Healthy People 2020 objectives that they are aligned with. For opioids, the medical product safety objective 2.3 is currently being redeveloped, but it is in alignment with that. Next slide, please. The numerator data comes from the surveillance system that we run here at CDC, the National Electronic Injury Surveillance System. It's a nationally representative stratified probability sample, and it's based on retrospective medical record review by abstractors looking for adverse drug events diagnosed by clinicians. Our denominator data, again, the unique recipients of dispensed prescriptions, comes by way of our colleagues at the Food and Drug Administration, and it is from Quintile's IMS Total Patient Tracker. This is a nationally projected estimate of U.S. retail pharmacies, and it's derived from a large database of retail, largely chain and other independent pharmacies, and they use it to, by way of proprietary methods, they estimate the total number of patients receiving one of these three targeted drug classes. I'm going to hand it off to my colleague, Dr. Shahab, for the next slide.
CDC. I am pleased to be presenting on behalf of the Federal Interagency Work Group on Anticoagulant Adverse Drug Events on federal efforts in anticoagulant adverse drug event prevention. In this presentation, I will provide examples of these federal efforts in the areas of surveillance, prevention, and research. Next slide. For improving surveillance, or better capturing the burden of anticoagulant ADEs, the ADE Action Plan recommended coordinating existing federal efforts to assess the health burden and rates of ADEs. To improve surveillance of anticoagulant ADEs, assessing the accuracy of diagnostic and procedural coding, including ICD codes, for anticoagulant-related bleeding events is important. Administrative data remain the cornerstone for identifying real-world burden of health events. However, it is well established that ICD-9 adverse event codes, or E-codes, underestimate the burden of anticoagulant-related bleeding. Further, with the implementation of ICD-10 in 2015, there is now a need to validate the use of ICD-10 codes for this purpose. Next slide. CDC has responded to this ADE Action Plan call to action and is now funding 2 studies to identify and validate ICD-10 diagnostic codes for anticoagulant-related bleeding. These data will be relevant to local benchmarking, for example, by health systems trying to quantify the burden of emergency department visits or hospital readmissions resulting from anticoagulant-related bleeding, quality measures such as those used by the Centers for Medicare and Medicaid Services and by health plans, post-marketing safety assessments, such as those conducted by the Food and Drug Administration, and to ongoing surveillance of the public health burden of anticoagulant ADEs, such as that conducted by the CDC. The studies are currently underway, with preliminary results expected in October 2017. Next slide. For improving oversight or policies related to anticoagulant safety, the ADE Action Plan recommended exploring opportunities including financial incentives and oversight authorities to promote ADE prevention. For outpatient settings specifically, the action plan identified a need to expand national healthcare reporting measure sets to include measures specific to anticoagulant safety. We do have nationally recognized quality measures for anticoagulation. However, these measures have not historically focused on whether anticoagulants are managed safely, just as to whether anticoagulants are prescribed. Next slide. In the new Centers for Medicare and Medicaid Services Quality Payment Program, CMS has responded to this call to action. 2 guideline-recommended and evidence-based practices for managing patients on anticoagulants are identified as being eligible for physician incentive payments. These are highly weighted measures and include documentation that over 60% of patients are participating in a systematic anticoagulation management program. This is for patients receiving warfarin or any other anticoagulant. Next slide. The other measure includes documentation that patients are being managed by other evidence-based practices, such as electronic decision support and patient self-testing or patient self-management for warfarin. Next slide. For improving prevention of anticoagulant ADEs, the action plan recognized the importance of fostering a comprehensive approach that addresses both anticoagulant safety, but as well as effectiveness. Although safe use of anticoagulants and preventing bleeding is the primary concern of the action plan, it is important to recognize that ensuring patients who are candidates for anticoagulants are also appropriately receiving them. In the U.S., it's been estimated that 1/5 of patients admitted with stroke may not be receiving therapeutic anticoagulation. Less than 1/2 of patients with atrial fibrillation who are eligible for warfarin may not be receiving it, and that over 3/4 of patients with venous thromboembolism may be non-adherent to warfarin. But we also know that clinician and patient concerns around toxicity or bleeding contribute to anticoagulation underprescribing or underutilization. For this reason, one stated goal of the action plan is to help advance the field of anticoagulation safety in hopes that it will also contribute to more appropriate utilization of anticoagulants. Next slide. CDC has responded to this call to action by collaborating with the Georgia Institute of Technology on development of a clinical decision support tool for mobile platforms to help guide clinicians and laboratory professionals in prescribing, monitoring, and switching of anticoagulants, as well as reversal of anticoagulant toxicity. The tool, Anticoagulation Manager, is currently undergoing testing, and testers are being sought. Please contact CDC, the Division of Laboratory Systems, if you're interested in learning more. Next slide. This slide just highlights some of the areas that the Anticoagulation Manager app provides clinical decision support, including dosing adjustment in the presence of renal dysfunction, selecting and monitoring appropriate laboratory tests, supporting information to help guide clinical decision-making around appropriate anticoagulant prescribing as well. Next slide. Lastly, the ADE Action Plan called upon federal partners to prioritize and coordinate federal research efforts for the identification and prevention of anticoagulant adverse events. This slide summarizes selected key research efforts currently being undertaken by the federal partners or being supported by federal funding to help advance identification and prevention of warfarin and new oral anticoagulant adverse events. With that, I will conclude my presentation, and I'm pleased to introduce Dr. Christine Lee from the Food and Drug Administration, who will be presenting on efforts in prevention of diabetes agent adverse drug events. Next slide.
Thank you so much, Dr. Shihab. Next slide, please. As the ADE Action Plan recommends for the diabetes agents, is to facilitate prevention efforts that are based on a patient-centered approach. The ADE Action Plan under diabetes agents supports strategies that incorporate shared decision-making in diabetes agent medication management where appropriate. In certain patients, intensive glycemic control, that is an A1C of less than 7%, may increase the risk of severe hypoglycemia without significant benefit. Patients and providers need tools to guide evidence-based treatments and shared decision-making. Next slide, please. Hypoglycemia, as is well known, insulin is the second most common drug associated with emergency room visits for adverse drug effects. There's also an increasing healthcare burden of hypoglycemia in the United States from 1999 to 2010. Rates of hospital admissions for hypoglycemia among Medicare beneficiaries have increased by 22.3% in comparison to a 39.5% decrease in the rate of hyperglycemia admissions. Severe hypoglycemia may result in serious consequences such as coma, seizures, and even death. Even mild hypoglycemic events may have consequences, including lowering health-related quality of life, higher mortality, increased risk of cardiovascular disease, serious fractures related to falls, automobile crashes, and even a higher risk for dementia. Next slide, please. As mentioned before by Dr. Powell, the ADE National Action Plan was burned into action in 2011, and there was a call to action for dissemination and implementation. The next couple of slides will go over very high level the the areas within dissemination and implementation. Next slide, please. As we'll show here in the next couple of slides, partnerships and actions with our federal partners along with our partnership with professional societies and academic societies. Next slide, please. In our dissemination efforts, or as what I like to call it, the amplification of message, there has been several efforts, including one that happened around 2 weeks ago at the FDA in which there was a public workshop addressing hypoglycemia harm in the older population. Additionally, coming up on November the 1st, ODPHP will be hosting a listening session looking at the patient perspective and living with hypoglycemia. Additionally, there has been partnerships with professional societies such as the Endocrine Society, ASHP, and others, healthcare professionals, including endocrinologists, pharmacists, and other healthcare professions, patients, and caregivers. Additionally, we have presented at conferences, including oral and poster presentations. The VA has developed patient videos specific to understanding what the patient is going through living with hypoglycemia. And additionally, there has been efforts in audience-specific key messages. Next slide, please. Additionally, along the lines of implementation, the FDA Safe Use Initiative has taken its role in implementing the research that it has funded. I'll go over the details of this in the next couple of slides. Under the Safe Use Initiative, additionally, there's been a social media project understanding how is best to communicate with those living with diabetes. Additionally, as I will talk about later on in our implementation strategies, implementation of the Safe Use Initiative research project with Kaiser Permanente through CMS TCPI network, or Transforming Clinical Practice Initiative, within their Practice Transformation Network, the Mayo Clinic. Additionally, the VA has its Hypoglycemia Safety Initiative. ARC has its SHARE approach. Additionally, ODPHP has an e-learning tool on its website tailored around individualizing glycemic targets and goals. And additionally, coming up in early November, the FDA will be having its own hypoglycemia CME-CE released. Next slide, please. As mentioned throughout the ADE National Action Plan, there are several key concepts that are being implemented and disseminated through its federal interagency work group, including the messages of individualizing glycemic goals, shared decision-making, understanding social needs and comorbidities, and always taking time to understand the patient's voice and engage. Next slide, please. As promised earlier, I'm now going to discuss very briefly on the FDA Safe Use Initiative project and its implementation strategies with CMS TCPI and its Practice Transformation Network, the Mayo Clinic. The FDA Safe Use Initiative has a goal to reduce preventable harm by developing, implementing, and evaluating cross-sector interventions with partners committed to safe and appropriate medication use. The Safe Use Initiative aims to expand the evidence base by developing and evaluating new options that allow the FDA and the broader healthcare community to enhance safe and appropriate medication use. It does this by the broad agency announcement, also known as the BAA, which is FDA Safe Use Initiative solicitation for research and development to support regulatory science and innovation. Next slide, please. Along the lines of implementation, taking research and putting it into practice, the FDA Safe Use Initiative funded a Kaiser Permanente pragmatic risk score for prescribers to identify patients at risk for severe hypoglycemia. This is a real-time risk stratification tool that has been designed to guide shared decision-making when modifying glucose-lowering therapy. The CMS Transforming Clinical Practice Initiative, or TCPI, is currently piloting this tool in their Mayo Clinic, or also known as the Practice Transformation Network. Thank you. Next slide, please. And now I'd like to turn it over to Dr. Sandbrink.
Yeah, thank you, Christine. So I'm going to present on the federal efforts in regard to opioid adverse drug prevention. I'm Pritam Sandbrink. I'm the Acting National Program Director for Pain Management in the Department of Veterans Affairs. Next slide. So over the last 1 or 2 decades, actually, the use of opioids has increased dramatically. And with this, as we all are aware of, have been unintended and serious health consequences and social consequences. Now, opioids cause a number of adverse drug events, both in the inpatient and outpatient setting. But the interagency workforce determined that the drug events related to overdoses, unintentional opiate overdoses, were really at the highest priority, and so that's what we've concentrated on in regard to associated morbidity and mortality. There are practical difficulties in collecting data that differentiate between the adverse drug events related to normal prescribing and those arising from opiate misuse and abuse. So therefore, the action plan recommended we recommend to seek harm from all patients who are prescribed opiate medication, as we cannot really differentiate between these groups. Now, despite the overabundance of all the opiate prescribing, the data actually in regard to opiate-related adverse drug events is rather limited. Now, we have the best data really from the CDC, and that's on the next slide. The next slide. Thank you. The CDC published a recent report that addresses the prescription and illicit drug problem in America, which is highlighted here, I think, as a figure. And then on the right side, you can see the annual surveillance report in regard to drug-related risk and outcomes. Now, this report is recent. The link is on the just below it, so please review it. It's a really detailed report about opiate prescribing, about drug use, misuse, and substance use disorder, about the overdose-related hospitalizations, emergency room visits, but then also in regard to the actual mortality and the CDC efforts. Now, in this report, the most recent data is from 2015, at least to the large extent. And that's on the next slide, though. I took this one figure from the report, on the next slide, which shows here the change in regard to the overdose death related to the different drugs. So these are the opioid CDC data in regard to the different opioids that are implicated. Overall, we actually have newer data since this figure was produced, and I entered those on the bottom. Unfortunately, in 2016, there was a further increase in regard to drug overdoses. In 2016, the preliminary data shows that we have over 64,000 patients killed by overdoses, and which is a rise of 21% over the data from 2015. And the most concerning ones, and that's really the hashed brown line already in the figure, you see the increase in the synthetic opioids other than methadone, as there's this dramatic rise since 2013. And last year, this has further increased now. So fentanyl and the other synthetic opioids accounted for more than 20,000 deaths in 2016, whereas 9,945 in 2015. So it's more than doubled. And on comparison, heroin is about 15,000, and opioid prescription medication, opioid pills, are 14,000. On the next slide. There are further examples here of federal and state-based surveillance system to provide us data on opioid adverse drug effects. On one hand is mentioned the CMS Part D overutilization monitoring system, the OMS report. The focus of this program is to identify the most at-risk beneficiaries for opioid utilization. And despite an overall increase in the number of beneficiaries in this program, CMS has seen a decrease in the number of patients that are actually considered overutilizers of opioid prescribing. I'm highlighting here also the VA Opioid Safety Initiative. This was started in 2012, rolled out nationally in 2013. It really is embedded in a much larger VA pain care transformation that includes education and training of providers and expanded access to non-pharmacological treatment modalities, including behavioral and complementary integrative health modalities. But among others, it includes this Opioid Safety Initiative dashboard with a number of parameters that we track now nationwide, and we can drill this dashboard down to individual facilities and individual prescribers. So it includes the data about opioid use overall, the long-term opioid prescribing, opioid and benzo co-prescribing, the high-dose prescribing, the number of risk mitigation strategies that are being utilized, including urine drug screens, PDMP checks, informed consents, which are all required by policies for our patients. On the right side in the figure, it shows the blue is a line in regard to the overall opioid prescribing in the Department of Veterans Affairs. So since the peak in 2012, you've seen a rather, impressive decrease by about 30 to 40% in regard to opioid prescribing. We're probably at data where we were originally about 10 years ago in regard to number of prescriptions issued to veterans. And on the bottom is the data for the high-dose opioid prescribing, which has seen an even greater reduction. I also want to mention the FDA adverse event reporting system. Now, this is for healthcare providers and patients. It's a voluntary program that collects reporting data, but it is mandatory for regulated industry, and it collects spontaneous reports of adverse events possibly related to drugs, drug products. And then lastly, there's the ARC Quality and Safety Review System that we've heard of earlier in this program already. On the next slide. Now, there are a number of evidence-based prevention tools to improve opioid prescribing. And so we've identified here opportunities that can be included into the prevention strategies and tools. So these could be on the inpatient and outpatient recommendations, and they're organized here according to the different priorities in the National Quality and Strategy. So for safer care, patient and family engagement, effective communication and coordination of care, science-driven prevention and treatment, and promotion of best practices within communities, stratified here by inpatient and outpatient tools and programs. On the next slide. In regard to evidence-based prevention, it's very important that we provide guidance to the providers nationwide. Many of you are aware of the CDC guidelines that are, I put the link up here that were published last year. I also include now here the VA-DoD guidelines. Those were published in February of 2017. These are available on an external-facing website, which is www.healthquality.va.gov. All our clinical practice guidelines are available there. They include tools for providers as well as for patients, patient-provider communication tools, patient information guides. So they are accessible for anybody to use. In addition, I want to mention our increased access to naloxone. The VA's initiative is called the Opioid Overdose Education and Naloxone Distribution, or END. One of the hallmarks is that we have broad inclusion of the veterans as no cost to the veterans in regard to copays. We've now issued more than 105,000 prescriptions to veterans nationwide. And it really is well aligned with the FDA's increased access to naloxone recommendations. On the next slide, I want to highlight a few other training and educational opportunities. According to the Presidential Memorandum from October 2015, all federal healthcare providers needed to be trained in regard to opioid safety and the heroin epidemic. That certainly has been accomplished across the federal systems. One particular training is the Pathways to Safer Opioid Use. It's an interactive online training tool which trains providers, and they can enter as a pharmacist, as a nurse, as a physician provider, but there's also a patient can enter. So it's a training tool that is really interactive. It's just fabulously done. And if somebody wants to find more out about it, please just check it out. It's a great tool. Now, there are other information that is available on NIDA. It has a medication resource page. It disseminates information in regard to causes and consequences of drug abuse and addiction, but also has screening tools and resources, including continuing medical education opportunities for providers. I want to mention the SAMHSA, HRSA collaboration, the Center for Integrated Health Solutions. It has a webpage that acts as a central place for information related to publicly accessible substance use and pain management trainings. The FDA REMS program, the Risk Evaluation and Mitigation Strategy programs, which is based on the industry in regard to education regarding extended release and long-acting opioid analgesics in particular. And then our VA academic detailing program. This is an in-person educational outreach. It is by healthcare professionals, usually pharmacists, that are specifically skilled in communication with providers. Our implementation began in 2014, and it has, the ability to, the pharmacists to do this have the ability to identify the providers who may be of greatest potential to benefit from their interaction, and then they have put together a really great number of outstanding educational tools and information brochures. It's really a wonderful program for us in the Department of Veterans Affairs. Together with the DoD, we have a joint pain education program. It's called the JPAP. We have modules and videos that are available on the DVCIPM website, which I listed also on the slide here. And next slide. So with this, I'm concluding here, and I will hand this over to Dr. Tefera. He's from the Center for Program Integrity at CMS.
Thank you very much, Friedhelm, for reviewing the VA's work, and good afternoon and good morning to the participants on the line. I'm happy to review the work from CMS, particularly from our role as the nation's largest payer to introduce incentives and offer oversight in addressing the opioid epidemic in particular. Next slide, please. As many participants know, our work is broad at CMS. I'll touch on a couple of our activities, including the Hospital Improvement and Innovation Networks, which many folks will recognize are an extension of the work we do in the quality improvement organizations. These organizations and networks support the nation's hospitals, patients, caregivers to implement and spread well-tested, evidence-based best practices and develop a learning collaborative to promote the minimization of adverse drug events for all the classes discussed, anticoagulants, diabetes drugs, and certainly opioids. There's also work at our Innovation Center to reduce hospitalization by benefiting from the specialization of our pharmacists across the country to avoid medication-related errors and focus on medication reconciliation. And recent legislation, the IMPACT Act, actually promotes the incorporation of patient assessments focused on medication reconciliation, and CMS is involved in disseminating policy related to that. Probably the most significant development recently was the Medicare Access and CHIP Reauthorization Act of 2015. That was the direction from the Congress to really have our agency as the nation's largest payer step away from the historical fee-for-service model and work to link quality measurement, performance to the payment of our clinicians. The MACRA legislation authorized two main arms, the merit-based incentive payment system and advanced alternative payment models. More information about both these arms can be found on the Quality Payment Program website, which is listed on the slide below, qpp.cms.gov. I'll be focusing on MIPS on the next several slides. Next slide, please. The MIPS program provides clinicians with a composite performance score that is based on 4 performance categories. Quality performance category that's based on infrastructure from the existing physician quality reporting system, an advancing care information for performance category, which is based on infrastructure from the electronic health record program in Medicare, a new performance category called clinical practice improvements activities that I'll discuss in a couple slides, and a performance category based on cost that's called resource use in the statute. All of these performance categories are described in detail on the Quality Payment Program website, qpp.cms.gov. Next slide, please. As an example for the quality measure performance category, I'd like to call out here one of the measures we have focused on atrial fibrillation management with anticoagulation. Clinicians would submit their numbers of patients who receive anticoagulation, and based on how clinicians perform relative to other clinicians nationally, that would impact their quality performance category, which would contribute to their overall score. There are over 270 quality measures in the MIPS programs, and we work to provide as many options as possible for clinicians in the wide array of specialties. Again, the total number of measures is described in detail at qpp.cms.gov. Next slide, please. Clinical practice improvement activities is really focused on working to measure the actions of clinicians in practice that matter most to their patients, to help improve their day-to-day care, and to identify activities that are not easily compensated in the existing fee-for-service schedule. There are 92 improvement activities in the first year of the MIPS program, and the proposed rule for next year has expanded that by over 20%. All these improvement activities are listed on the qpp.cms.gov webpage, and I'll go over several in the coming slides. Next slide, please. For example, to promote thoughtful diabetic management, there is an improvement activity that asks clinicians to attest to whether the majority of their patients, greater than 60% in the first year and 75% in the second year, are participating in or have committed to a documented glycemic control goal, and that the clinician's office, including nurses and other staff, are working to identify risks to maintaining the patient's adequate glycemic control and communicating directly with the patient to minimize adverse effects of the glycemic agent of their choice. Next slide, please. On the opioid front, there are two existing activities. The activity described here is having the clinician attest to using their state-based prescription drug monitoring program when they dispense Schedule II prescriptions for greater than 3 days. Again, what we're trying to do here is acknowledge the fact that taking the extra step to access more information to become a more thoughtful, informed prescriber takes time, and we want to monetize that into their performance score for the clinical practice improvement activity, which will contribute to their overall MIPS score. Again, this and the other 92 improvement activities for the first year are described in total at qpp.cms.gov. Next slide, please. As we focus on minimizing adverse drug events in the opioid space, working with colleagues at CDC, we're trying to develop another improvement activity for year 2 and onward that will focus on clinicians completing the CDC's guideline for prescribing opioids course that will be web-based. That will be based on the chronic pain guideline that was released in 2016. We continue to work with our colleagues at CDC to identify ways to make it easier for clinicians to become more aware of the best current evidence to inform their prescribing. Next slide, please. Having concluded that review, I'm going to pass the phone back to Dr. Powell.
Great. Thank you very much, Tess. I want to thank all our 6 panelists from AHRQ, from CDC, from the Veterans Health Administration, from FDA, and then most recently from CMS. For those who are still on the line, we have about 5 minutes in which we can entertain some questions and direct those questions to one of our 6 panelists. While people are thinking about those questions, let me just point you to the slide that is currently displayed, encouraging you to follow HHS Prevention on Twitter for our latest trainings, webinars, and conferences that will support the good work that you all are doing in disease prevention and health promotion. And secondly, I would encourage you to sign up for healthcare quality and patient safety updates at health.gov/HCQ. We have gotten a couple of questions, and I will just read the questions and then pose them to one of our panelists. So one of the questions that came in, I think, falls in the domain for AHRQ, and we have Noel Eldridge on the phone. The question was, for the inpatient measures, what does adverse event included in each of the numerators? So, Noel?
Yes. The quickest way to answer that is to suggest that anyone interested contact me by email at noel.eldridge@ahrq.hhs.gov. And if you had trouble writing that down, you could just Google my name and the word and the letters AHRQ, and you'll get my email address. For the hypoglycemic agent adverse event, it's basically patients that got their blood glucose tested during the stay, then had a blood glucose under 70 during the stay, and also had some symptom such as confusion, coma, sweating, or some clinician response such as administration of D50 during the stay associated with the low blood glucose, and that would count as an event. For the warfarin, heparin, and low molecular weight heparin adverse events, basically for warfarin and heparin, it's based on a lab value such as the INR or the PTT, plus some symptom like a GI bleed or a large hematocrit job. For the low molecular weight heparin, there's no particular special blood test that's included. So we look for things like abrupt cessation, other indicators such as a transfusion absent a surgical procedure, as well as a patient symptom like a GI bleed or a large hematocrit drop. And again, if you send me an email, I will give you a little more detail on that.
Want to address it. And that question is, what % of physicians actually have selected the opioid and glycemic MIPS improvement activities? Tess, is that one we can field to you? Tess, I wonder if your mute button is still on?
Sorry, can you hear me now?
Yes, please go ahead.
2017 is the first performance year for the MIPS program, so we will not have information available about what improvement activities were selected until the end of the performance program. Having said that, improvement activities are all by attestation only. So considering that there are close to a dozen states, probably more now, that have mandatory prescription drug monitoring program registration and utilization of prescription drug monitoring programs has been increasing. We're hopeful that this will create a vehicle to reimburse clinicians for their time and effort to be more thoughtful prescribers.
Thank you, Tef. Also, there was another, Tef, are you still there?
Yes.
Yeah, this question just came in, if you can answer it briefly because we're at the top of the hour. Can you tell us when the ADE measures might be included in mandatory reporting via the MIPS or other payment programs?
So the current measures for MIPS were finalized in the MIPS rule in November of 2016. That is for the current year one MIPS. Currently, we have a a notice for proposed rulemaking that's open for year 2, and that notice has the list of the proposed measures for year 2. There's been an expansion of options or other measures offered for year 2, but that's something that's we're waiting to receive feedback on from the various stakeholders. The final rule will be coming out, I suppose, imminently. It should be out before November 1st.
Directed to Dr. Shihab, when will the ICD-10 validation work be completed for bleeding events?
Yes, hello, this is Nadine. Hopefully within the year, but we have no firm date as of yet. We're currently working on the analysis.
Great, thank you. Thank you, Dr. Shihab. Unfortunately, our time has come to a close. We have had some other questions, one regarding the downloading of these targeted measures, and some other questions about work in anticoagulants. For those who are still on the line, for any questions that we did not cover, we will try to address these and post those questions and answers on our website at health.gov. There will also be a recording of this webinar, which will be made available as well. Again, I want to thank everybody who joined us on this ADE Targets and Measures webinar, and especially thank our panelists, Noel Eldridge, Andrew Geller, Nadine Shihab, Friedhelm Sandbrink, Christine Lee, and Dr. Lemina Tefera. Thank you all so much. Bye-bye. This concludes our webinar. Thank you.